According to the 2010 Infectious Disease Society of America Guidelines for the Management of Febrile Neutropenia, the first step in management is to accurately assess the patient's risk. This risk assessment will allow you to make decisions regarding the recommended route of delivery for empiric antimicrobial therapy, intravenous versus oral, and the appropriate venue for management, inpatient versus outpatient. This case illustrates an example of a high-risk patient due to her profound and prolonged neutropenia, as well as her comorbid conditions, in this case hypotension and new-onset abdominal pain. She has therefore correctly been triaged for inpatient empiric therapy with intravenous antimicrobials. The IDSA guidelines recommend that most high-risk patients be treated empirically with a single agent with broad gram-negative coverage and activity against Pseudomonas. Options include piperacillin tazobactam, an anti-Pseudomonal carbapenem, ceftazidime, and cefepime. Of note, fluoroquinolone monotherapy is not recommended. The choice of which agent to use should be informed by a patient's prior antimicrobial courses and your local antibiogram. In addition, this patient has certain risk factors and clinical findings that suggest the need for extended spectrum gram-positive coverage, in this case with intravenous vancomycin. While vancomycin is not routinely indicated in patients with febrile neutropenia, the severity of her presentation with hypotension reduces the margin for error and justifies its use. The IDSA guidelines point out that randomized studies comparing empiric regimens with or without vancomycin in this population have shown no differences in the outcomes studied. They also recognize that the indiscriminate use of vancomycin in particular has contributed to the growing prevalence of drug-resistant gram-positive organisms in these patients. Thus, the guidelines recommend the empiric use of vancomycin in a limited set of circumstances, namely, hemodynamic instability or other evidence of severe sepsis, pneumonia, positive blood cultures for gram-positive bacteria pending identification and susceptibility results, clinically suspected serious catheter-related infections, evidence of acute skin or soft tissue infections, documented colonization with MRSA, drug-resistant pneumococcus, clinical suspicion of septic shock due to viridin streptococci bacteremia, which can be resistant to beta-lactams and fluoroquinolones. Risk factors for this particular condition include severe mucositis, use of ceftazidime for empiric gram-negative coverage, and prophylaxis with fluoroquinolones. Of note, cefepime, the carbapenems, and piperacillin tazobactam do provide excellent coverage against viridin strep. However, because the margin for error is small in the setting of shock, empiric extended gram-positive coverage can be warranted. Again, the 2010 IDSA guidelines recommend the careful use of vancomycin and other extended-spectrum gram-positive agents, including linezolid and daptomycin. They encourage the cessation of these agents 2 to 3 days after their initiation if no susceptible organisms are cultured.